This conference will now be recorded.
Okay, we're going to go ahead and get started this morning. Good morning. This is Jeffrey Popkin. I am a independent contractor working with the Bakersfield ARC on this home and community-based waiver project through funded through excuse me, the Department of Developmental Services, California Department of Developmental Services, and the Kern Regional Center. This grant is a 2-year grant. This is the first year of this 2 years, and there are a number of activities that we are doing every month. There is a newsletter that comes out usually the first or second week of the month. There are 2 communities of practice, one for vocational and day services, and then one for residential. And then finally, there is this webinar. In addition, we are doing a series of trainings through an organization called CQL, which is the Council on Quality and Leadership. And they are providing training for individuals free of charge. If you go to the CQL website and look up the different training opportunities, most of the training opportunities run from $100 to $800 depending on the training, and you guys can get those for free from top level people throughout the country. So with that, I would like to go ahead and get started. All right. So today we're going to be talking about some issues related to health and safety. And again, I'm Jeffrey Popkin, and this is part of the series that we're doing uh, for both day and residential providers who are under the HCBS waiver final rules. Um, to get started, we need to first talk about continuing education credit. This class is accredited by Community Care Licensing and Kern Regional Center. Community Care Licensing because it's a Kern Regional Center approved class. You must attend the entire webinar to obtain the CEUs, the Continuing Education Credit. You must identify yourself at the beginning of the presentation on the screen or in the chat. I saw there was one person who didn't have a name on they were on the website. So if you could, please either put your name in under your picture or put it in the chat so we know who you are, so we can make sure that you do get the credit. If you're also phoning in, you need to make sure your name uh, there so that we know who you are and how to get in touch with you if we need to. After this course is over, you need to email to Irene at Bakersfield ARC the 3 concepts that you learned from the presentation. So in the presentation today, I'm going to be talking about a number of things. Pick 3 that you learned and send those to Irene. It can be just bullet points, can be a paragraph, doesn't have to be a whole book, but we want to make sure you are on the course for the whole hour, especially for those of you, or in this case, hour and a half, who are don't have your camera on. We want to make sure that you were focusing on this and not on your phone or on some of the other multiple things that you as providers need to do every day. So, uh, and finally, if you are asking for credit, we ask that you approach Irene within 30 days because it's very difficult for us to keep track of all of the training for folks because we're doing a number of different trainings. If it goes on for a protracted period of time. So please, if you are wanting the 1.5 units of credit for today, that you get a hold of Irene with your 3 concepts as quickly as possible. Okay, First of all, I'd like to talk about some training opportunities that are becoming up or available. Uh, this training opportunity, which is being put on by the California Department of Developmental Services, is for clients and their families. So this is not so much for you, but for the people that you're serving, and also if they have families or relatives or guardians or other people involved in their lives and they would like to know more about the home and community based waiver standards, uh, this is an opportunity to do that. So it's understanding your rights. The home and community based service requirement went into effect in March of 2023, so, supporting important rights for individuals who receive HCBS. Some examples of HCBS are day programs, or day services, employment services, and group homes. So if you're one of those and you have people in your home, they can take this training. It's on the it's a web-based training. There are two dates that's available: Friday the 9th and Saturday the 10th. And there you can find the Zoom registrations. This is online at the DDS site. I believe many of you received an email from Kern Regional Center sharing this. AO is the company that's doing it. They're excellent providers. They did 4 workshops for our program, Bakersfield ARCs, last year, and they were all excellent. So it's a very good provider out of Northern California that will be putting these on. And I would encourage you to encourage clients and or their families to attend this training. Okay, now these are some of the trainings that um, Bakersfield ARC will be offering through this grant coming up that are through the Council on Credit on Quality and Leadership, and strongly encourage you to attend. I've been on a couple of them now and have been in the system for 46 years and still learn new things and new perspectives and new ways of looking at things. They've got some wonderful tools that they give out. They also have videos, which they then make available to you. So they send you at the end prospectus on a number of different things. Yesterday they gave resources on how you can write objectives for IPPs and things. So good resources. On February 22nd, everyone has rights, which they will again repeat on May 14th. Now, rights, as you give people the ability to make their choices and do what is important in their lives, you will find that behavior improves, that your program runs smoother, clients are happier. It's one of the most important aspects of the home and community-based waivers to assure people to have their rights. Then on February 15th, and all of these trainings are from 9 to 1. So they're 4 hours in training. And in many cases, they may run till 12:30 or whatever, but it's scheduled from 9 to 1. Person-centered thinking, the basic foundation for home and community-based waiver services is that it's all about the individual who we serve and their hopes and dreams, what's important to them, what's important for them. And that's what person-centered thinking is all about. So this is an introduction to person-centered thinking. Your Kern Regional Center offers a person-centered planning class, which is almost, I think, 4 days. And it's a very involved process. But if you need an introduction or you want your staff to have an introduction, good course to take. And that's being offered twice, once on February 15th and then again on June 25th. Then we have another training, which is called the PALM, and that will be a 1 week training. There are 12 spots for that. As at this point, Valerie, do you know how many people we have signed up?
From my understanding, we only have 3 slots left out of the 12. So if anyone is interested, remember this is an $800 course that you're going to do Monday through Friday. Tuesdays at your own basically your own time. You need about like 4 to 5 hours dedicated to that. And also Thursday and the other days you will be on a webinar in person. You have to have your camera on. And I just want to remind everyone, these CQL trainings, I know everybody's been used to over the pandemic. You know, you sit there and you just learn. On these, they're interactive. So you're required to turn on your camera. You're required to participate. That, you know, it is something that is beneficial for you because it helps you actually grasp everything that you're learning, and it makes you take yourself out of your personal life and putting yourself in the individuals that you're serving's position, so you're seeing it from their point of view. But yeah, we have about 3 spots left, so if anybody is interested, or if you know somebody that may be interested, you can just give the contact information, either myself or Irene, and I'll put that in the chat here in a second, so we can get that to them.
Now, just one thing, clarification. When Valerie said this is an $800 course, that's what it would cost if you actually went to the CQL website. Through this grant, you get it for free. So basically, Kern Regional Center and the Department of Developmental Services is picking up the tab for your training. So that's an excellent opportunity. But it is a full week commitment. So if you're going to go on it, you can't say, well, I'll do Monday and I'll do Wednesday and Thursday. No, if you're going to do it, you have to commit to Monday through Friday, and it's what, 9 to 4 every day. So it is a full day commitment. So I know that's very difficult in this day and age when staffing is such an issue, but it's well worth the training. It is the POM was developed prior to the HCBS rules, but they really do work well together. So if you're doing the 21 areas that the POM has, you're doing everything that you need to do for home and community-based waivers. So you'll be in full compliance, and you'll be doing things with a level of excellence and quality that assures the best interest of the people that you're serving. Then on March 28th, exploring communications. Now, not everyone communicates verbally. Some people are that they don't use language. Other people have different ways of communicating. Some people say that, when you have an individual who is having some challenges in your facility, that's their way of communicating that they're not happy with what's occurring. So this is a way to talk to people, to learn about their communication, to figure out new ways of communicating with your clients. On April 18th, we have the 3 E's, the Foundation of Informed Choice, and we'll be talking a little bit about the 3 E's this morning, just very briefly, and so we'll do that in a moment. Then we have 3 more trainings that throughout, again, the person-centered thinking, again, community building and connections, working with clients about how to make community. So when we talk about, hey, we're going out into the community, well, you and I don't talk that way about when we go out and do things. So let's talk about how we build a community for people who have intellectual and developmental disabilities. And then finally, embracing the dignity of risk, which is part of what we're going to be talking about today, just very briefly. So again, I encourage you to take these nationally accredited, very high level individuals making these trainings. And again, free of charge, well worth your time to take these. Okay, so briefly, I shared that we were going to talk about risk and informed choice. The 3 things that are involved. So when developing a individual person-centered plan for someone, we want to look at what their needs are, what their wants are, and really find out from the client what they would like to learn, what they would like to experience, what new things. So try new things, get out of your comfort zone, navigate the world around you. Despite the importance of the three E's, people with disabilities who receive services often face significant external barriers in making decisions that are impacting their life. So you want to educate your clients, teach them about new opportunities and new things that they can do. Many of our clients have had a very limited experience throughout their lives. I was surprised one day when I was still a case manager and was taking an individual for a pre-placement visit over on the Central Coast. And when we went to the facility, the client was very excited because although this was a young man, he had never seen the beach. He had never been to the beach. And so this was a first for him. And so we stopped and we spent some time there. We talked about it. So he got a little bit of education. He got some experience. He got exposure. And then so he could make decisions in the future if he wanted to go back at some point to the beach or have other experiences related to that. So we want to try to give people opportunities to try new things. Now, in trying new things, sometimes things don't always go right. I mean, people try to make new friends and they get rejected. People go on the city bus and something goes wrong and maybe they get hurt or they get lost. So there are times that when we try, even though if we do education, experience, and exposure, things can not go the way we were hoping. And that's part of life. For you and I, we do things and there's a certain amount of risk. For any of you who drove to work this morning, there was a certain amount of risk in getting into your car and driving to work. There's a statistic out there that most accidents, car accidents, occur within 5 miles of someone's home because that's where you drive the most often. So there's a certain amount of risk that's involved with life, and that's what we're going to be talking about today. When risk happens, so when something goes wrong with the risk. Now, the Department of Developmental Services, again, the California Department, every year by state law has to put out a document that talks about the special incidents that have occurred. Now, when they talk about special incidents, they're talking about risk management and mitigation. Mitigation being that how you go about making sure it doesn't happen again or that it is addressed somehow. So we want to look at that. Now, this is a report that came out in December of 2023. So it's a brand new report, just came out last month. And it basically looks at the fiscal year. The state of California runs its budget and its services based on a July 1 through June 30th year. So this was the July 1, 2021 to July 1, 2022 is the most recent report. So what we're going to talk about, first of all, is some definitions. What are things that require you to do a special incident report, sometimes referred to as a GRE? Now, definitions. Now, a medication error, when an individual under vendor care experiences one or more of the following situations: wrong medication, wrong dosage, wrong time, wrong route instead of by mouth, maybe some other way, or wrong individual, so somebody else gets their medication. Years ago, when I was working for the Kern Regional Center and was involved with risk management, we had the highest number per capita by our size of special incidents of any regional center in the state. And what it turned out is that we had a lot of individuals who were living in supported living services and were not taking their medication right. And that meant that the supported living provider then had to do a special incident report. And so if a client misses a dose, that also is considered to be a medication error and needs to be reported. Missing persons, those conditions must apply. These conditions must apply. The vendor has communicated with any law enforcement agency in any way and described the individual as missing to that agency, or has filed a formal missing persons report with law enforcement agency. Now, it's been my experience. I've talked to some of my colleagues in Southern California and other places. In some of the larger urban areas, they won't take a report for at least 72 hours. Here locally, if you let law enforcement know that the individual has a developmental disability and it has a certain amount of challenges that can affect their ability to independently interact in the community, they will respond quicker. And so I've had in the past a pretty good response from local law enforcement. One of the things that I used to do in many cases was I would call the business number, not necessarily 911, and I would talk to the watch commander, the person that was on that particular shift, that was the commander, and explain what was occurring and ask that they get the word out. And that way, so I could give a more in-depth explanation about the person's needs. Now, 911 works as well. I found, for me anyway, the watch commanders and oftentimes was a better way to go for getting it. But make sure that you get a hold of law enforcement in one way or the other and let them know if you have a client who is missing. Mortality, any individual death, regardless of cause. So even a natural cause death, somebody who has been ill for some time and has. Please turn off your mic.
I don't know if they can.
What?
I don't know if they can. I'd probably do it yourself if you can.
Okay, hang on, let me.
It's the caller 01 that just arrived.
Okay. I will get it though. There we go. Let me go back onto this. Okay. Other definitions: suspected abuse, reasonable suspected abuse, and reasonable means what someone who would see it might think it was abuse. So you don't necessarily always know, but if you suspect, you're better off to report than not report. Exploitation, including physical, sexual, fiduciary, that's financial, emotional, mental, or physical and or chemical restraint. So any type of abuse that's occurring for that person needs to be reported to as a special incident GRE report. Suspected neglect, reasonable suspected neglect, including failure to provide medical care for physical or mental health needs, preventing malnutrition or dehydration, protection from health and safety hazards, or assistance in personal hygiene, or the provision of food, clothing, or shelter, or exercise, the degree of care that reasonable person would exercise in the position of having the care and custody of an elderly or dependent adult. So this has to do with just not taking care of business. So if you're not protecting their health and safety from hazards, you're not assuring that they're receiving the food and water that they need, their medical needs are not being taken care of, their mental health needs, their clothing, shelter. I don't think this is happening in any facilities I've ever ran across or day services, but it is part of the definition. Unplanned medical hospitalizations. Now, unplanned hospitalization due to the following conditions: respiratory illness, colds, flus, RSV, pneumonias, seizure related. So somebody who has a seizure that requires them to go to the hospital, cardiac related, heart attacks or other types of things related to the heart, internal infections. So an infection that is causing, high fevers, other difficulties, diabetes, wound skin care. So if the person has wounds or skincare issues that require them to be hospitalized, nutritional deficiencies, and then also unplanned psychiatric hospitalization. So if somebody ends up in a psychiatric hospital. Now, unplanned psychiatric hospitalizations mean unplanned or unscheduled hospitalizations due to a psychiatric condition when all the following conditions are met. The discharge diagnosis indicates that the individual was admitted to the hospital for a psychiatric condition. So the person went into the hospital because of not a medical problem, but because of a psychiatric condition. The individual is not conserved and does not consent to the admission, so that the person was placed into the hospital basically without them saying, yes, I want to go in. They were committed into the hospital. And the individual is conserved, and the individual's parent, legal guardian, or conservator does not consent to the admission. So if they are an adult who has a conservator, and the conservator was not involved in the admission to the psychiatric hospital, and the legal mechanism used to accomplish admissions is the Welfare and Institutions Code, section 6500. So some of you may have heard the term sometimes used, oh, the client was admitted under 6500. 6500 is the section of the Welfare and Institutions Code which says that someone is a danger to themselves or other. That is normally a 72-hour hold, so that somebody can be held in a psychiatric facility for up to 72 hours. Now, at the end of that 72 hours, if the person continues to need psychiatric assistance because of the danger to themselves or others, there are conditions that can be extended both for another 72 hours, for 30 days, etc. And that's all spelled out in that section of the law. So if you're having a significant psychiatric issue in your program, you contact law enforcement, they evaluate the person, the psychiatric team out of Kern Behavioral Health also may come out, and they feel that the person is a danger to themselves or others, and they're the ones who make that decision. Then the person can be involuntarily held under that section of the law. 600. Important to know, this is not something that you can do or that the regular doctor can do. It can only be done currently by law enforcement or people, the medical people at the hospital. There was just a bill introduced this last week in the California legislature to make it so that other mental health professionals could have someone committed under 6500. But now it's currently limited to make sure that we assure people's rights and that we're not putting people in a psychiatric facility against their will. So it's limited as to who can make that decision. Also, victims of reportable crimes, including the following: robbery, aggravated assault, larceny, burglary, and I don't know, I must have cut it off because this and rap, I don't know what that means. But I know what that was, rape. Excuse me, it somehow got cut off there. So, but if they're involved, if they're sexually assaulted, that also goes in there. Now, the California Code of Regulations, Title 17, and many of you have heard the term Title 17 before, and that comes from the California Code of Regulations. Now, in California, we have the Lanterman Act, which is the Welfare and Institutions Code, starts at section 4500 and goes from there, and that is the law. Now, the law says that the Department of Developmental Services shall make regulations on how to implement that law. And so the Title 17 is where is basically the state's section of regulation specifically related to health and safety. Now, if you were to go into the California Code of Regulations, there are a whole series of them. So there's a series on, there's a title specific to professional licenses, to contractors, to prisons, to construction. There's a number of them. Title 17, section Division 2 is specific to the Department of Developmental Services. Now, if you go into Title 17 and you go to section, and those double S's there is an abbreviation for sections, 54.327, 54.327, that is the requirements for special incident reporting by vendors and long-term healthcare facilities. Now, can anyone tell me what the time frames are for making a report? Just turn on your mic for a second and share when do you have to verbally report and when do you have to report in writing?
In the first 24 hours.
For the verbal report.
Verbal.
When is the written report?
48.
Yeah. So you have to from the time of the occurrence. So you want to make sure that you are reporting consistent with Title 17 requirements. So this is what you do have to report. I just gave you the definitions, so that gives you a better idea of what these things mean. But reasonable suspected neglect, including failure to provide medical care for physical and mental health needs. So let's say a client is been complaining that when they urinate, it burns, and maybe there's a little bit of odor from the urine, and the facility says, "Oh, that's no big deal. Let's let it go." And they let it go for a period of time, and it turns out the person has a bladder infection, UTI, and it doesn't get taken care of timely, and that would be a special incident. Preventing malnutrition or dehydration. Again, making sure that the clients are eating well, hydrating. We live in a climate that can get very hot during the summer months, and especially for those clients who are taking certain types of medications that can maybe be, they cause them to excrete fluids that diuretics was the term I was looking for. Then you need to make sure that they stay hydrated to prevent dehydration. Protection from health and safety hazards. So if you see things in your home that can create a health problem or a safety hazard, you've got to address that. Assistance in personal hygiene or provision of food, clothing, shelter. So if you're not assisting the person as needed in those areas, exercising a degree of care that's reasonable person would exercise in the position of having the care and custody of an elderly or dependent adult. Again, this is the reasonable person standard. What would a reasonable person do in that situation? Okay, long-term care requirements for special incident reporting by vendors. The following, if they occur during the time that the consumer was receiving services and supports from any vendor or long-term healthcare facility. So while they're with you, if these things occur, the consumer is missing and the vendor or long-term care facility has filed a missing persons report with law enforcement agency. Reasonably suspected abuse, exploitation, including physical, sexual, fiduciary, emotional, physical, and or chemical restraints. Chemical restraints refer to giving someone large amounts of medication, especially maybe antipsychotic, tranquilizing, anti-anxiety medications, as a way to control certain behavioral occurrences or challenges, and that's considered to be chemical restraint. So the least amount of medication intervention is really the best course, and you should work with your physician on finding ways to address these issues. Okay, a serious injury, accident, including lacerations requiring sutures or staples. So if they have to have stitches or staples, puncture wounds requiring medical treatment beyond first aid. So if you're taking the client to their doctor's office, to an urgent care, to a emergency room, fractures, dislocations, bites that break the skin and require medical treatment beyond first aid, internal bleeding requiring medical treatment beyond first aid, any medication errors. Again, we mentioned those earlier, medication reactions that require medical treatment beyond first aid. So if the person has a serious reaction to a medication and needs to be taken again to their doctor, the urgent care, the emergency room, or burns that require medical treatment beyond first aid. So that would be, in many cases, second or third degree burns that do require the person to be seen by a medical professional. Any unplanned or unscheduled hospitalization due to the following conditions. Respiratory illness, including but not limiting to asthma, tuberculosis, chronic obstruction pulmonary disease. If a person has seizures that cause them to be hospitalized, cardiac related, including but not limited to congestive heart failure, hypertension, and angina. Internal infections, including but not limiting to ear, nose, throats, gastrointestinal, kidney, dental, pelvic, or urinary tract. Diabetic, including diabetic related complications. So again, these are hospitalizations. Wound care, skin care, including but not limited to cellulitis and decubitus. Decubitus are bed sores, open wounds, usually sometimes referred to as pressure sores. And for that could be from a lack of a person being turned, that they're very limited to no mobility, and they're sitting in one situation, or they're maybe in a wheelchair all day and don't have adequate cushioning that can prevent the pressure buildup in a particular area that can cause skin breakage and infection. Nutritional deficiencies, including but not limited to anemia and or dehydration, and involuntary psychiatric admission. So all those are things that you need to report, and again with 24 hours and then the 48 hours subsequent to the regional center to make sure that you are in compliance with the law. Now, there's also the following regarding or when there's an occurrence, a death of a consumer, regardless of cause. So it doesn't matter how the client passed away, even if it's natural causes. The consumer is a victim of crime, including the following: robbery, including theft using a firearm, knife, or cutting instrument, or other dangerous weapon, or methods which force or threaten the victim. Aggravated assault, including physical attacks on a victim using hands, fists, feet, or a firearm, knife, or cutting instrument, or other dangerous weapons. Larceny, including the unlawful taking, carrying, leading, or riding away of property. So somebody stealing, except for motor vehicles, from the possession, constructive possession of another person. Burglary, including forced entry, unlawful forced entry, or attempted forced entry of a structure to commit a felony or theft herein. And then finally, rape, including rape or an attempted to commit rape. So these are all areas that you need to follow the protocol. And we're going to talk some more about, it's not just about reporting. There's a lot more involved with a special incident and that's going to be later in this presentation. So um, from that report that I showed you earlier, that Mission Analytics, the company that works for the Department of Developmental Services, put out in December of 2023, they looked at a number of years in terms of special incident reports. In the year 2020-21, again, July to June, there were 263,394 people in the DDS population, of which 68,510 were in out-of-home placement. There were 20,333 special incident reports. There were also 15,874 COVID reported. So if you remember, during the height of the COVID pandemic, the Department of Developmental Services was requiring providers to report COVID infections to the department. Now, the 2021 fiscal year would have been from July 1 of 2020. The stay-at-home order and really the full protocols for COVID started in about March of 2020. So this is the time when COVID was in fairly rapid pandemic. In 21-22, again, you can see the numbers. The number of special incidents went up, but then the population of developmental services went up by over 20,000 clients. And the non-COVID, the non-Title 17 COVID ones went up considerably. So where the population went up 20,000 for DD clients, the population for non-Title 17 COVID requirements went up by 10,000. So almost, a fairly large increase. So these are the number of reported incidents. This is system-wide. Unfortunately, I wasn't able to find a breakout specific for Kern. I'm sure it does exist, but it wasn't available on the Developmental Disabilities website. Now, what they're doing is they're saying, okay, if you have 1,000 clients, so you take 1,000 clients, how many of them have a special incident during that year? Okay, or how many special incidents are there for that client population? Some clients may have more than one incident during that year, so that's taken into consideration for these statistics. So number of reported incidents per 1,000 individuals served. So how many reports did we have for 1,000 individuals served? Now in 2017-18, there were 69.1 incidents per 1,000 clients. So for every 1,000 clients, there was approximately 69 reports. In the following year, 67.7. Interesting enough, what you start to see come the 2019-2020 year is a decrease in the number of Title 17 SIRs. And then you remember March of 2020 is when we went into the stay-at-home order, and then you started to see that 2.9% down at the bottom there, because it was only the last 3 months, and the pandemic was really just starting to increase. The number of consumers, so just slightly under 3 clients per every 1,000, was developing COVID-related issues that required special incident reporting. But it's kind of interesting because the number of special incidents went down, and it didn't actually say in the report that Mission Analytics did for DDS, but I'm assuming, and I think it's a fairly reasonable assumption, that as people were staying at home and not really going out into the community as much, as day programs were closed, as everything else was changing. There were fewer special incident reports. And that's sort of borne out in the following 2 years. So if you look at the 2021 report, and you can go back to 17, 18, special incidents went from just about 69 down to about 56. So a reduction of about 14 events per 1,000. So for every 1,000 people, 56 reports were submitted. But then you look at the difference for COVID, and there were 43.7 reports per 1,000 cases. Now, the last year that this reporting was available, and again, the mission gets their information from DDS, and they're usually a year or two behind. So the most recent report that we have is from 2021-22, and at that time there were 54.9, so basically 55 special incidents and 66.1 COVID-related reports sent to the department. So I really do believe, if you look at that for Title 17, the reduction occurred because clients were less actively involved in services outside of their living arrangement. So many clients were getting their day program via Zoom. The facilities were involved in less activity. There were more restrictive protocols that were being implemented. So for a number of reasons, it reduced the number of Title 17 SIRs. Most of you, if not all of you, are using the THERAP program, and they call them GREs. So the numbers of reported cases of special incidents based off of the reporting criteria that I mentioned earlier went down. So, and I think it's a fairly reasonable assumption, but again, it is an assumption that it was related to the more restricted activities that were available to people during this period. Now, non-mortality and mortality, Title 17 per 100,000. So in the 17-18 year, there were 62.4 of the 1,000, so 62.4 people out of 1,000 who had a special incident report was non-mortality, with 6.7 being clients who passed away. In the following year, 18-19, it was 61.5 to 6.2% for fatalities. In 1920, which again was when we first started seeing COVID in March of 2023, it dropped to 56.5 for non-mortality and was fairly consistent, about 6.5 for mortality in terms of number of people out of 1,000 who died in that year. If you look at the following year, again, a reduction in the number of non-mortality SIRs down to 48.2, where the number of people who died during that period of time went up. So overall, the number of SIRs decreased by about 7 people out of 1,000, but the number of people who died from during that period of time went up by 1.2 persons per 1,000. And then the following year, again, the numbers were lower, 48.4, fairly consistent with the year before for per thousand for SIRs. Number of deaths went down a little. I think in 2021-22 year, and again, this is an assumption, and so some people might disagree with this, but our protocols really were much more effective. The vaccine came out. People who had previously got COVID had some immunity, so there were some decreases, a slight decrease in the number of people who died from that. But again, that's an assumption on my part. There was no data that was analyzed that could come to a conclusion on this. So it's a subjective opinion on my part to say what I just did, but that's my prerogative, right? Anyways, the rate of non-mortality incidents reported per 1,000 individuals by location. Okay, so this is in the different fiscal years. So the rate of non-deaths incidents reported per 100,000 by location. So if you look at where the person lives, that is where the largest number of incident reports occurs. And that, special incident reports are for people who live in a vendored facility. So this doesn't have individuals served who live at home with their parents or in their own home. But if they are in supported living services, group homes, family care homes, foster family, that's reflected in the individual residence. So there were, again, you saw that decrease in the years where there's a COVID pandemic, and there's not specific research to back it up. But again, my assumption is that it related to clients not being as active and more restrictions in place related to what they were able to do during that period of time. The other one is in other locations, and again, I think one of the big drops in that is because much of that relates to day services that people are involved with, and many of the day services were either greatly restricted in terms of the programming that they were providing, or were providing primarily Zoom programming. But as I've said a number of times already, there isn't. This is just the data. There isn't an analysis to say why that's the case. So these are my assumptions. Rate of non-mortality incidents reported per 100,000 individuals by non-residential location. So these are for clients who were not in a residential care type setting. So this would be basically outside of a residential setting, job site or community. It was 3.8, and then it went down to 2.2 and 2.8 over those 30 years. Short-term health facilities, so the client went into a hospital. What were the number of reports that were coming out? And again, this is per 100,000 clients. I mean, per 1,000 clients, excuse me. So there were 2 reports per every 1,000 clients in the system over 2 years, and then down to 1.9. Other, and I don't know specifically what that is, day program or school, and look at the drop there. And I think that has a lot to do with the fact that day programs, for the most part, were not operating the regular type programming either at a site or in the community in the 2021 year for the most part. 21, 22, many programs started up again, and so at some point during the year, so the rate went up a little for that. Home of the family, so the client went to their own home, and it occurred not in the vendor's program, but outside of the vendor's program. But in the case of, let's say, for example, supported living services or some other services, the vendor needs to report, or for example, if a person that you support went home for a visit and came back and had unexplained bruises, and you then reported it to a regional center. So it happened while they were potentially visiting family, and so that's how it got reported. In transit, so if the client was in public transportation, on a bus service for going to and from programming, you were transporting the client to appointments or other places. Those were where reports occurred. So breakdown on Title 17 reportable incidents by type in 2021-22. So in the most recent year that we have available, the largest number of reports had to do with medical hospitalization. Again, the unplanned hospitalizations, which you saw in the definition that we just shared earlier. An injury, a client was hurt, and again, if they needed stitches, broken bones, refer back to Title 17 for all the specifics. Medication error was next, where clients wrong dosages, wrong person, missed dosages, etc. Suspected abuse made up 10% of all the reporting. Psychiatric hospitalization, where the client needed to be placed in a hospital under that Welfare Institutions Code 6500 for danger to self or others. Missing person, client disappeared, you filed the appropriate reports with law enforcement. And suspected neglect, so that the client wasn't receiving the services that they were supposed to be receiving. Victim of crime. And then finally, mortality. How many clients? So 12% of all the special incident reports for the most recent reportable year that they have Mission Analytics tracked was a 12% mortality rate. Again, that was 21, 22 was still in the midst of the COVID pandemic. So I don't know how much that really reflects in that mortality statistic. Okay, non-mortality SIRs per 1,000 individuals and fiscal year 2000 by incident type. So these are, we're taking out mortality and we're comparing it to 2 years. And again, medical hospitalization is the number one type of reporting that is done for clients under the Title 17 rules. Injury and medication errors were fairly close in terms of the number of reports related to those. Suspected abuse was next, followed by psychiatric hospitalization, missing persons, suspected neglect, and then victims of crime. Now, some of you are saying, okay, you're giving me a lot of statistics, and there's one or two more that I'm going to be showing you. Why is this important? What do I need to see all of this? Well, if you're looking at your facility and you're trying to figure out, okay, how do I prevent accidents, medication errors, other challenges from occurring missing persons. What is the likelihood? I mean, obviously it's individualized to your facility, but if you're looking at the system, this is where most of the incidents are occurring. So it may end up helping you with a focus on this is an area that we need to pay some some attention to in terms of our planning. And when we're looking at sitting down as a group and looking at ways of making sure that our clients are safe and healthy within our facility, these are areas that we can focus on to make sure that we're addressing. Okay, and this is again the hospitalizations that have occurred over the years. That you see, it's about almost 20 reports out of every 1,000 persons who are in the developmental services system for the first couple of years. Goes down a little bit in 1920 when you start to see the COVID hospitalizations. And then 2021 is when we see the largest number of COVID population hospitalizations, which is 2.4 out of every 1,000 clients ended up in the hospital during the 2021 year. And then a much smaller number in the 21-22 fiscal year. Then deaths per clients, 100,000, I mean, 1,000, I keep saying 100,000, per 1,000. All other reported deaths, 6.7 in 17-18, 6.2. So that means for every 1,000 special incident reports, we lost 6.7 clients statistically in that year, 6.2 the following year. Then in 1920, which is again goes to through June of 2020. So March through June is when we really started seeing the epidemic. We saw 0.2% of the client deaths that we saw out of that 6.6 were related specifically to the COVID pandemic. The following year, when we were pretty much in the height of the epidemic and before vaccines and and as we were developing more safety protocols, the numbers went up. Following year, the number went down back to fairly close to what it was in previous years. So you can clearly see that there was a significant impact due to COVID in terms of mortality for our individuals. Okay, next slide. This is from a document, and it's a lot of stuff on the screen, so bear with me here. Ensuring beneficiaries' health and safety in group homes through state implementation of comprehensive compliance oversight. So this is a document that was put out by the U.S. Department of Health and Human Services. All right, and it really talks about what states can do. Now, when we talk about what states can do, that translates in terms of what you can do. Now, this document is specifically was written for group homes, but it also can pertain to any type of adult service. So if you have an adult day health service, other types, I'm going to pause for just 1 second here. Sorry about that. Okay, model practices for state investigation, management, and investigation. Okay, first of all, reporting and notification. So that's what you're starting with. You're doing a report and you're notifying the regional center, you're notifying licensing, and if there's others involved with that individual, you may want to active family, conservator, other folks, you want to make sure. Then incident review. Okay, how are you reviewing that? What happened? How did it happen? Is there something we can do differently? We're going to investigate. We're going to look into why it happened, the who, what, when, where, and why that we sometimes talk about. Okay, what's a corrective action plan and its implementation? And then look at trend analysis. Is this something that we're seeing often in our facility? Is this the first time we've ever seen this? Is this something that's happening over and over again? When I was at Bakersfield ARC, they have a monthly meeting in which they review any and all SIRs, GREs that were filed that previous month and look into what happened. Where did it happen? Why did it happen? And what can we do to make sure that that doesn't happen again? And one of the interesting things that they found over time when doing some analysis, because they also looked at employee injuries too, although this is, our talk today is specific to client, but they also looked at employee injuries, and what they found was that when somebody first comes to work for you, they tend to have more likelihood of potentially having a special incident type event because they're new and they haven't learned everything, and they may not follow all the health and safety protocols, etc. Then the rate goes down, and if you have a long-term employee, after about 4 or 5 years, it starts going up again a little. And the reason for that, they surmised, was that people kind of get a little bit lazy. Oh, I know how to do this, and they don't necessarily follow all the protocols. So knowing that, we went back and worked with those individuals to make sure to reinforce that they knew the protocols to try to bring the numbers down. So one of the things that you really want to do as a provider is to look at the trends in your facility. A number of years ago, there was a situation where a facility had 2 or 3 individuals who, over a period of, let's say, I don't even remember, 5, 6 months, all developed bowel impactions and needed to be hospitalized and treated. Well, what about the diet or some other issue in that facility was making it so that this was occurring? Because it's not really that common to have that occurring to multiple people over a short period of time. And so there's a need to go back and look at, okay, so what do we need? Well, why is this? First of all, why did it happen? Who did it happen to? What can be done to mitigate it so it doesn't happen again? And then what trend are we seeing here so that we can prevent this from occurring within our facility? Identify causes and circumstances. So if you have a death in your facility, what occurred? Was this a client who had respiratory issues and had for many years, and when they first came to your facility, they were identified, they were taking medication for that, and it's just their respiratory condition, which was chronic, became worse, and then finally to the point where they needed to be hospitalized and passed away. Was there something you could have done differently? Were they seeing their doctor with regularity? Where warranted, take corrective action. So what can we do differently in the future to try to prevent mortality? And if you do have deaths in your facilities, identify if there's any trends to what's occurring, and you want to systematically respond and evaluate their efficiency and also your reporting. What are you doing? The federal government sometimes calls it closing the loop. So it's one thing to make the report, to show people that, okay, there was this event that occurred in our facility and we're doing what we need to do. We're reporting it. And there is that thing about what's being done to, mitigate. Many times people say, oh, well, client will be in the hospital and then they'll return back to the facility once they're healthy. But if there was something that can be done to try to prevent that event from occurring again for that client or for other individuals that you serve in your program, then you want to look at that. So it's more than just making the report. It's analyzing the report and seeing if there are things that you can learn from that to make the program even better. Again, assessing incident reports, assessing response. So how did you respond? And review of the incident. Assessing investigations, conducting corrective action plans, assessing identifications of response to the incident trend. We had a situation many years ago that where a client was sexually assaulted, and we did all the right things in terms of getting that client seen medically. Responded to, did the reports, we did everything else. What we didn't do was we didn't do anything in terms of follow up, in terms of counseling, in terms of checking in with that individual about their feelings about the event, doing some of the work that was really necessary to help that person uh, you know, feel better about themselves. And, so that was something that we missed. So that's something you want to really make sure that you take into consideration, that you're looking at all of it. Oversight of service planning and delivery, periodic assessment of performance. Again, we at Bakersfield ARC, we had those monthly meetings where we looked at all of the incidents that we had that month and tried to figure out why, how, what we could do to prevent that from occurring in the future. Review network capacity and accessibility and compliance monitoring of required outcomes. So we want to make sure that we're doing what we need to do, that we're complying with all the rules that we fall under specific to Title 17. But then what are we doing to make sure that we have good outcomes? We had a incident that wasn't good. We don't report the good, happy things that happened to client. Client got a job. You don't do a special report to the regional center on that and follow up and all that. This is about things that happen which are unfortunate or bad for the individual served. So what are we doing to try to change those outcomes, to make things better in the future? Again, this is from that report. Incident management and investigation to ensure responses to serious incidents in the community-based services system that timely and effectively resolve the immediate event or solution. So we wanted, what are we doing to take care of what happened? So if the client got a laceration and we took them to the urgent care clinic and that took care of it, then that's step one, to promote the safety and well-being of the individual involved in preventing a reoccurrence. Two, to ensure that the facts and circumstances of serious incidents are timely and effectively reviewed and investigated as required. So, like I say, like that bottom box where it says, what did you do, or what is your follow-up? And the regional center is going to ask you, how are you following up on this? So, if let's say for that example, that laceration, the follow-up is is wound care, is to make sure the area stays clean. Maybe they gave you a salve that's an antibiotic cream or something else that, and they want you to maybe make a return trip to have the stitches removed or whatever it is. What are you doing to make sure that you're doing things timely? And then you want to review and investigate. Okay, so how did this happen? Where the client or the individual you serve fell and and maybe there was a throw rug that probably shouldn't have been there, and by removing that, the client won't trip or fall in the future, as an example. So look into if there's something that you could do to make sure it doesn't happen to that individual again or to other individuals, to ensure that trends and patterns regarding serious incidents are identified and addressed for appropriate recommendations for corrective actions, including not limited to additional provider and staff training to focus on both quality assurance and improvement, necessary changes, reforms, and specific protocol services and delivery to enhance the standard operating policy. At one event that occurred while I was at Bakersfield ARC is that we had a recycling center, and an individual who was working in an area related to glass recycling stepped on a pretty sizable piece of glass, and although they had protective shoes on, it went through the shoe and actually a fairly serious laceration to the foot, the sole of the foot occurred. And staff who had taken the first aid training, the CPR and first aid training, and were provided training on how to handle serious wounds, didn't do it correctly, didn't follow the regular protocol. Now, we did get the person to the emergency room. Everything got taken care of. The person got the stitches they needed, got everything. But we as an organization said, wait a minute, we need to retrain our staff to make sure they fully understand what they need to do in that situation. Because when that situation occurred, we didn't handle it in the most appropriate manner. And although we did make sure everything was safe and everything got taken care of, it wasn't consistent with what the Red Cross training would have had us do in that situation. So let's go back and retrain staff to make sure that we do that. We also said, okay, so how can we make sure that that area where that glass is stay safer? And we can also look at the recommendation for type of boot that we look to give to have people wear back there. So there were a number of things that we could do to change the outcome from occurring in the future, and if it did, how we could handle it better in the future. So that's part of what you want to do in terms of closing that loop. So it's not just about reporting the event to regional center and then to follow up. Yeah, the client went back to the doctor a week later and she's fine now. So that's not enough. That doesn't do it. Okay, and this is my final slide, and then we will take questions or comments. To ensure that recommendations for corrective actions associated with serious incidents are timely and effectively implemented. So again, this is what we did where I was working. We went ahead and we retrained. We brought in the Red Cross certified individual that we used, and had staff go over that particular section of the manual again to ensure that implementation corrective actions are effective in preventing or reducing the occurrence of the serious injury. We did some changes to the area in terms of how glass was stored and how, if something got out of the containment area, how we made sure that we swept it up and got it back into where it needed to be and that it wasn't out there. We also looked at the safety equipment that people were wearing when working in that area. to ensure government officials, providers, support coordinated agency, and designated protection and advocacy entities receive timely and effective notification of serious incidents. So you want to make sure that you're reporting to regional center and to licensing if you are a licensed facility. If you're not a licensed facility, to adult protective services or long-term care ombudsman. And then finally, to ensure public reporting related to overall safety and well-being of individuals, supported by community-based service system and supports for quality assurance of community living options for individuals. So you want to, be as transparent as possible. You want to make sure that you are, if you're providing services in the community, that this is part of your quality assurance plan of how you're going to make sure people are safe, and that if something does happen, that you do an analysis, you do things to make it better for both that individual and follow-ups for that individual, but also system-wide, you're looking at how you're doing things to make sure that this doesn't occur again in the future. So with that, I'm open to questions. Any questions about or comments on the presentation today? You just go ahead and open up your microphone, and you're welcome to come on. Okay, it sounds like there's no questions. Again, what I really want to stress is that special incidents are more than just making the GRE report to Regional Center and to the other agencies involved. It's the follow-up, both in terms of the individual and the environment and everything else, that's just as important. And looking for trends to make sure that it's not happening with other people in your facility. It's not happening, over time with that individual again and again, because then you maybe look at something that you could do differently for that person. So it's about, so when we talk about health and safety, it's more than just getting people to doctors, and I think it's how we do our business, our ethic of making sure that when in essence bad things happen, we're doing everything we can to correct it and to make sure that it doesn't happen again. And all right. Again, any questions or concerns anybody has like to raise? Hopefully, some of you will be on the trainings. Next month, we have, I believe, 2 CQL trainings, and I will be doing a community of practices on this second Wednesday of next month at 10 a.m. for day and vocational, and then the third Wednesday of the month for residential, and then the fourth Wednesday will be a webinar like this, and we will be sending out shortly information on all of those. So again, there is a wealth of information out there, and we're going to continue to be providing these. One of the things that Leslie from Kern Regional Center shared with us is that if and when they come out, or when they come out to your facility to do your assessment, one of the things they're going to be looking for is how much training have you been involved with, and how much have you shared with your staff about the trends in home and community-based waiver and about clients. So the more you're involved in these trainings, the better it is for you, because you'll know how to do it. Also, when Regional Center comes out, you'll know what to say, and you'll have the manuals and the documents available to show that you are following the rules. And with that, unless there's any questions or comments or concerns, I'm going to go ahead and sign off. I'll just wait another minute here. All right. Well, have a great day and a great week, and we'll see you in the near future. Bye
Thank you,
now.
Jeff.
Bye-bye.
Thank you.
Thank you, Jeff.
All right, bye.
You're